Hi everyone, welcome to our presentation on primary progressive aphasia. We hope you enjoy and learn something new. We will start off by explaining characteristics regarding primary progressive aphasia, or PPA. PPA is actually a form of dementia that specifically inhibits speech and language functions. The etiology is unknown, but we do know that it is progressive and degenerative with a slow and gradual decline. The average age for the onset of PPA is around 60 years old, and it tends to affect males more than females. PPA is associated with some other neurological symptoms, such as dysphagia, oral apraxia, right central facial droop or weakness, right extremity weakness, and limb apraxia. In the early stages, memory, other cognitive abilities, and personality remain intact, but as PPA progresses, mental faculties begin to deteriorate. Now we are going to explain some early signs of PPA. Those with PPA may experience word finding and naming difficulties, particularly when it comes to speaking and writing. They may also experience semantic or phonemic paraphasias, which we have learned about in prior classes. Circumlocutions, or talking around a word when the person has word-finding difficulties, is common in the onset of PPA. Those with PPA usually have troubles with following conversations, especially in a group setting. Initial signs of PPA don't always present as deficits. In fact, skills such as memory and other cognitive abilities remain intact. Similarly, those with PPA in the initial stages will be able to perform daily living activities with minimal deficits. Since PPA is progressive, these skills that remain intact initially will begin to deteriorate.
PPA, also known as cortical degeneration syndrome, involves degeneration of nerve cells in the language regions of the brain. Atrophy typically occurs in the left frontotemporal parietal region in those affected. However, deficits associated with PPA can present in a variety of ways depending on the source of atrophy. Specifically, those with atrophy in the frontal region will typically experience deficits in motor speech, syntactic abilities, and lexical retrieval. Those with atrophy in the posterior temporal regions will experience phonological errors and disruptions to speech fluency, consisting of halts and pauses. This will make a lot more sense once we explain the three subtypes of primary progressive aphasia, which all have different sources of atrophy.
There are three main types of PPA. We will explain more about their specific speech and language characteristics in upcoming slides. There is non-fluent/agrammatic PPA. Atrophy appears in the left temporoparietal cortex and dorsolateral prefrontal cortex of the brain. In logopenic PPA, atrophy appears in the left temporoparietal region. In semantic PPA, atrophy appears in the anterior temporal lobe. It is important to note that these are initial atrophies of PPA. Since it is a degenerative disease, atrophy will continue to evolve as PPA progresses.
Each variant of PPA presents with language-specific characteristics that can be identified during diagnostic analysis, which we will cover in the next slide. For a brief synopsis of how each variant presents, we made this chart that explains the speech and language-related characteristics associated with each subtype. Clients with a non-fluent agrammatic variant of PPA typically have a slow and effortful rate of speech, with articulatory errors like distortions and deletions, just to name a few. The impaired ability to form sounds with their articulators can be classified as apraxia of speech. They typically have an inability to form grammatically correct sentences known as paragrammatism and have limited linguistic complexity. The defining feature of this variant is the impairment of syntax. Those affected often omit small grammatical words, use word endings and verb tenses incorrectly, and mix up the order of sentences. These clients find it increasingly difficult to speak, but can typically still recall the meaning of individual words. Clients with the logopenic variant of PPA have a more normal rate of speech, However, they frequently halt and produce long pauses in their conversational speech. Speech can be perfectly fluent in conversation, but become hesitant as they search for the right word. They usually have difficulties with word retrieval as well, resulting in consistent use of circumlocution to access target words. However, those affected are still able to recall the meaning of words. They present with substantial paraphasias, meaning their speech production consists of unintended syllables, words, or phrases. Their ability to repeat is heavily impaired, causing them to present like clients with conduction aphasia. Clients with the semantic variant of PPA have a normal rate of speech, but have significant word-finding difficulties. These deficits can affect their comprehension of meanings of words, as well as finding or naming people and objects. The hallmark of this variant is the progressive loss of the meaning of words. Those with the semantic variant are able to repeat phrases and sentences, however, their own speech may become difficult to understand because they often omit or substitute words. Overall, their comprehension is significantly impaired. As this variant progresses, those affected will begin to use more general names for specific things. Diagnosis usually consists of a two-step process that includes first diagnosing the client with primary progressive aphasia, then diagnosing the variant. When diagnosing, a client must present with prominent language deficits that have been consistently declining for at least 2 years. Deficits must be limited to only issues relating to language, with cognitive and behavioral functions falling within normal limits in the early stages of the slow but gradual progression. This will, however, begin to deteriorate over time. Things like neurological disorders, cognitive disturbances, episodic memory and executive functioning deficits, as well as initial behavioral disturbances, must be ruled out in order to make a proper PPA diagnosis. It is typically diagnosed using specific behavioral assessments that we will cover further in the presentation. The second step in diagnosing PPA is confirming the variant to better understand the client's prognosis and etiology. This will also aid the clinician in creating functional goals and treatment approaches for the specific client. Here we have the criteria needed in order to make a proper PPA variant diagnosis. If the client is diagnosed with the logopenic variant, impaired word finding and repetition would be present. This client must also present with 3 of the following impairments, which are phonological errors, spared motor speech, spared single word comprehension, spared object knowledge, and absence of agrammatism. If a client is diagnosed with the non-fluent agrammatic variant, agrammatism or apraxia of speech should be noted. This client must also present with 2 of the following impairments, including spared object knowledge, spared single word comprehension, or impaired sentence comprehension. If the client is diagnosed with a semantic variant, anomia and poor word comprehension must be evident. This client must also present with 3 of the following deficits that include impaired object knowledge, surface dyslexia or dysgraphia, spared repetition, or spared motor speech.
Our patient is Luis Lopez. He is a 58-year-old Hispanic man who has presented with language difficulties throughout the past 2 years. Previous imaging shows focal atrophy in the language zone of his brain. Luis also presents the neurological symptoms of dysarthria and right extremity weakness. His wife is the one who initially brought him in to the physician due to Luis having speech and language deficits, unclear articulation, difficulty with word finding, and right extremity clumsiness. All of these factors were considered to give him the diagnosis of primary progressive aphasia, non-fluent agrammatism subtype. It is also important to note that his wife does not think that Luis really understands the progressive nature of this disease. Luis lives with his wife and daughter and used to work as a retail clerk at the local home improvement store. He recently had to change positions to a stock clerk because communication issues impeded his ability of keeping his initial position. Lewis loves to interact with others and enjoys playing poker and rummy with his friends on the weekend. Lewis uses an organizational tray when playing poker as a modification tool to decrease his confusion. He often becomes frustrated with his word-finding difficulties. This frustration has led Lewis to become depressed and to become less social. Lewis is extremely motivated to participate in therapy and hopes to develop some skills to help him communicate more effectively. This is an international classification of functioning, disability, and health models specific to Lewis. It explains the areas that Lewis struggles with, how it is impacting his everyday life, his environmental factors, and attitudes towards diagnosis. This provides crucial information that will guide our therapy plan as a clinician. We will put Lewis's needs and wants at the forefront of our goals. At the top of the chart, you will see Lewis's diagnosis of primary progressive aphasia, non-fluent, a grammatism subtype. It is shown that he has difficulty with word finding and expressive languages. These deficits attribute to his difficulty having a conversation. That difficulty led him unable to continue as a retail clerk and struggle socializing with friends. The personal factors of Lewis is that he's a 58-year-old social man who's motivated for therapy. He is becoming slightly depressed for the fact that he can't interact with his friends the way he used to, and having some coping modifications for his everyday life, such as an organizational tray discussed previously in the slides when it comes to his poker and rummy games. Environmentally, Lewis lives with his wife and daughter, who are both super supportive of him. His wife was initially the one who referred him to physicians due to some deficits that we discussed previously. She presents some major concerns that her husband doesn't fully understand his diagnosis and the progressive nature of it. That is something that us as a clinician should really focus on in the future for therapy.
Listed here are some assessments we decided to administer Lewis. First, we administered the Western Aphasia Battery Revised to get a sense of Lewis's performance at baseline. We decided to administer the spontaneous speech, repetition, naming and word finding, and writing subtests. These subtests target areas that Lewis has shown deficits in and can help us as clinicians create an appropriate treatment plan to target his needs. For the Communication Activities of Daily Living, 3rd edition, Lewis placed in the 55th percentile rank, which is just about in the average range. This assessment is beneficial to use because the client can respond in a different communication modality other than speaking, which reduces the linguistic demand on the client. Since we have discussed both the WAB-R and CATL 3 in class, we will not go into too much detail regarding these assessments. Lewis was also administered the Progressive Aphasia Severity Scale, also known as the PASS. This is used to determine the severity of the aphasia. It can be repeatedly administered over time to track the course of PPA, which is important considering the nature of this disease. The last assessment we have for Lewis is the Geriatric Depression Scale. This is used to check for potential mood disorders to see what types of counseling may be needed. It can be administered to the client's spouse as well. More information about Lewis's performance on the PASS and the GDS will be explained soon.
As Ava mentioned, we chose to use the Progressive Aphasia Severity Scale, or PASS, during our assessment of Lewis. The PASS is a clinical instrument used to rate presence and severity in 13 domains of speech and language, 10 primary and 3 supplemental. I'm not going to discuss all of them, but some of the domains include articulation, fluency, comprehension, reading, and writing. Specific details about each of them are on the slide for you to read more about, so it's easier to follow along when we discuss Lewis. Because PPA is a progressive degenerative disease, It is helpful as clinicians that we have a baseline of the person's strengths and weaknesses, hopefully in the early stages of the disease if we can catch it quick enough. One important aspect of the PASS is that it's designed to be administered at multiple time periods to monitor change over time. A baseline score shows us the individual's relative strengths that we can capitalize on during treatment and also shows us the areas that the person might already be struggling in. When the PASS is administered again, we're able to see how the disease has progressed and affected each domain. This allows us to modify goals to help the person be as successful in communication as possible. In an article by Sapolsky, the authors recommend 3 steps a clinician should consider when determining the PASS score. First, the clinician should have the client's caregiver, in this case Lewis's wife, fill out a questionnaire about their current speech and language. Second, the clinician should interview the client and whoever filled out the questionnaire separately. During the interviews, it is important to review the answers to the questionnaire to get a clearer picture of the individual's abilities. At this time, it is important to discuss goals for treatment and what the client and their family want to get out of therapy. Third, the clinician should administer relevant parts of a formal assessment. In this case, we chose to administer the WOB. After completing each of these steps, the clinician uses all of the information gathered to complete the PASS worksheet, rating each of the 13 domains on a scale from 0, which is normal, to 3, which is severe. Now we are going to discuss Lewis's PASS score. We had Lewis's wife Rose fill out the PASS during our first meeting with him. Her responses to the questionnaire are attached as a handout that you can refer to so that you can get a picture of Lewis's current speech and language abilities. We've also included some examples of the types of questions you would see on the questionnaire on this slide. The top question is asking about Lewis's word retrieval and expression. His wife noted that when he struggles to come up with words, he says the wrong word, pauses, uses fillers, or describes the word. The next question is asking about his fluency, and she reported that he pauses and hesitates when speaking. The bottom question is asking about Lewis's writing. His wife reported that it is more effortful, and he makes spelling mistakes that he typically wouldn't have made before. After we read over the questionnaire, we interviewed Lewis and his wife separately. Because Lewis does not currently have any cognitive deficits, he was very aware of his speech and language difficulties. He agreed with what his wife wrote on the questionnaire and mentioned that he is becoming increasingly upset and depressed because of these difficulties. We took all of this information into consideration, and it helped us to develop his therapy goals, which we will discuss later. After reviewing how he did on the WOB assessment, we filled out the PASS worksheet and determined Lewis's score. One interesting aspect of the PASS is that when you are scoring a domain, it is recommended to give the person the benefit of the doubt. This means that if you're between 2 ratings, you should give the client the milder score. As you can see on the slide, most of his speech and language abilities are in the normal to very mild range, but he scored mild in articulation, fluency, and writing. He scored moderate in word retrieval and expression, his main areas of difficulty.
The next informal assessment we covered was the Geriatric Depression Scale, or GDS for short. The GDS is a 30-item yes-no formatted screening tool to assess depression in older adults. Participants are asked to complete the questionnaire based on how they have been feeling recently. The GDS can be self-administered or presented as an interview. We chose to assess Rose for potential mood and mental health disorders that could be associated with the progression of her husband Lewis's diagnosis. Within this information, we can cater our counseling efforts to better support Rose's mental health during this process. You can also see Rose's completed questionnaire in the handout that we included with this if you'd like to follow along as we go over this slide. 1 point is given for each answer that is indicative of depression. For example, if you look at the sample of Rose's questionnaire on the slide, you can see number 10 that reads, "Do you often feel helpless?" Rose responded to this question with a yes. Her response is correlated with 1 point that would be added to her total score. All questions associated with a depressive-like response are added together, resulting in a score associated with normal mental health, which is 0 through 10, moderate depression, which is 11 through 20, or severe depression, which is 21 to 31. You can see this scale listed on the slide next to Rose's sample. Sorry, I want to make a correction there. It's 21 to 30 for the severe depression. We chose to administer this screening tool in an interview-like fashion to allow Rose to express how she is truly feeling throughout and state her concerns. She conveyed sadness associated with her husband's state throughout the questionnaire. In the sample, you can see that several of Rose's responses indicated depression. Her total score of 14 indicates that Rose may present with moderate depression at this time.
We will be re-administering the PASS and GDS on the same scale to account for any correlation in the state of Rose's mental health with the progression of Lewis's diagnosis.
After our formal assessment of Lewis, we've come up with a summary of his strengths and weaknesses. His most noticeable difficulties are currently in language expression and speech. His automatic speech is within functional limits, but the other areas of his language have already begun to be affected by the disease. His repetition is impaired for multisyllabic words, and he has difficulty with lexical retrieval. He is non-fluent in conversations and demonstrates semantic and phonemic paraphasias. We also observe that he is aware of the rules of language, but his difficulties are affecting his pragmatic language. His speech is slow and intelligible to all listeners, but he has inappropriate prosody. His spastic dysarthria contributes to articulatory distortions and dysprosody, and his sentences are typically 4 words or less. Lewis does not currently demonstrate any issues with comprehension of yes-no questions, executing commands, or understanding stories. The only issue in regard to comprehension that he explained was that he found it harder to understand conversations when he was talking with multiple people. This was frustrating to him because it is difficult for him to enjoy playing poker with his friends. Lewis's word level and sentence level reading are intact and within functional limits. It was observed that his oral reading ability decreases as the length of the word increases, but he is able to spell common words when given the word verbally. We also observed during the assessment that Lewis's written expression abilities are beginning to decline as a result of the disease. His copying, writing to dictation, and drawing abilities were all within functional limits. However, his self-generated writing consisted of semantic and phonemic paraphasias. The presence of these paraphasias are mirrored in his verbal expression. Cognitively, Lewis is not currently experiencing deficits in attention or visuospatial skills. His procedural, semantic, and episodic memory are within functional limits. As of right now, Lewis is able to drive himself to work, remember the tasks he must complete while at work, and continues to remember anniversaries and birthdays without difficulty. His executive functions for problem solving and reasoning are intact. It is important to remember that as the disease progresses, these cognitive abilities will decline, but currently he is able to complete and participate in his activities of daily living with little to no difficulty. Lewis was alert, pleasant, and sociable throughout the assessment. He is aware of his difficulties and attempted to self-correct whenever he realized he made a mistake. Lewis is looking forward to beginning therapy as he is extremely motivated to improve his speech and language. However, this determination to improve leads us to believe that he does not fully understand the progressive nature of the disease, and this is something that we plan to address during therapy.
This target model for acquired language disorders has become altered to fit Lewis's deficits and diagnosis. His attention, memory, executive functions, and visual spatial skills are all currently intact. His reading and comprehension skills are normal. His writing skills present with mild to moderate impairment, and his expression is moderately severely impaired. It is important to note that this will change as the disease progresses with time. Aspects that are not impacted now will eventually become impaired. Lewis will be seen in an outpatient clinic with services by a licensed speech-language pathologist. He will be seen 2 times a week for 30 minutes each session. Our first set of goals will target Lewis's word retrieval skills. His long-term goal will be to improve word-finding abilities in order to improve his functional communication, with a short-term goal to name 7 out of 10 personally relevant words using semantic circumlocution in a generative naming task to increase functional communication in the workplace. The chart provided will show how the target words will be divided in an attempt to make them relevant to the home improvement store. Semantic circumlocution is a conversational strategy to talk around a word when trying to produce it. It adds more information in an attempt to bring the word out. The added information may add more clarity to the other person involved in the conversation to come to a conclusion. This therapy task will emulate a situation that Lewis may come across at work. I, as the clinician, may ask Lewis, "Where may I find the light switches?" This may pose much difficulty for Lewis because he cannot find the word for aisle 7. He may circumlocate with words such as next to or across from and describe the area in which the lighting aisle would be in. This would hopefully end in Lewis finding the correct response as aisle 7, but would minimally give the customer more information for them to find the aisle. This strategy would focus on the words and information provided in the chart so that the information may carry over into the workplace. It is helpful for Lewis to be provided with these strategies when communicating with others.
In addition to working on generative naming and problem-solving tasks, we think it's important to include the use of compensatory strategies in Lewis's treatment. Our long-term goal requires Lewis to utilize learned compensatory strategies to increase expressive language and word retrieval. We plan to introduce strategies like writing and gesturing in our treatment to present new ways of communication that will be useful to Lewis as his diagnosis progresses. He has begun to have issues with expressive language in conversations, so these compensatory strategies will be effective in his communications with others while building his confidence to still communicate given his situation. Our short-term goal with Lewis requires him to explain a card game using his preferred mode of communication with 75% accuracy independently and 100% accuracy with cued compensatory strategies from the clinician. We believe it is important to capitalize on the verbal communication Lewis has now while still teaching him to use compensatory strategies to enhance his output. Having Lewis explain a card game relevant to his interests, like rummy or poker, to the clinician using strategies of his choice will prepare him for real-life situations that he may run into when communicating with his friends during their game nights. The clinician will ask Lewis to explain the rules of rummy as the two of them actively play the game. Lewis will be provided a pencil and paper to use if he has difficulty expressing the rules verbally. The clinician will encourage him to utilize writing to get his point across. While Lewis will have the choice to choose writing or gesture, we want to emphasize writing because Lewis has intact writing skills at this time and it will provide him a meaningful mode of communication. In Lewis's variant of PPA, writing may remain relatively intact, so we would like to stress its usage to Lewis. Providing him with the strategies that will be functional for him to continue activities of daily living will continue to help his confidence when communicating with others. This goal will prepare him for functional modes he may rely on in the future as his diagnosis progresses.
Counseling is just as important as treating the aphasia. With counseling, the clinician can address any questions or concerns that the client or caregiver may have. 3 forms of counseling can be provided. These are educational counseling, supportive counseling, and partner counseling. Educational counseling involves explaining information regarding PPA to both the client and caregiver to ensure that they understand the nature of the disease. It is important to truthfully explain facts, but also be cautious of the client and caregiver's thoughts and feelings while receiving this information. Supportive counseling involves the SLP addressing the emotional worries of the client and caregiver. Partner counseling involves the SLP providing strategies to help the caregiver effectively communicate with the client and vice versa. This can include partner communication training, where the caregiver attends sessions with the client and is involved in therapy to learn how to effectively communicate. Here are some goals for Lewis that address counseling. Long-term goal. Lewis and his wife will utilize PPA compensatory communication strategies with guidance from the clinician across 3 therapy sessions. Strategies that Lewis's wife can use while speaking to him include, but are not limited to, a slow rate of speech, asking simple questions, and providing enough wait time. This falls under the partner counseling category. Another long-term goal we have for Lewis is Lewis will demonstrate a comprehensive understanding of the nature of PPA across 3 therapy sessions. This falls under the educational counseling category. Short-term goal. Lewis will create a brochure regarding PPA to present to his friends with guidance from the clinician over the course of 2 therapy sessions. This also falls under the educational counseling category. Lewis can use this brochure to explain his PPA to, for example, friends that he plays poker with, or family members who may not understand PPA. This ensures that Lewis, as well as those around him, understand the particulars of PPA.
The goals we have in place now will provide Lewis with meaningful communication at this time. However, as his disease progresses and more degeneration occurs, Lewis will unfortunately lose more abilities. Counseling will remain a consistent aspect of therapy as it is necessary for the well-being of both Lewis and his family's quality of life. We do want to note that while participating in an aphasia support group was listed in the textbook as a therapeutic goal for Lewis, we think that support groups involving others with aphasia may not be in his best interest given the nature of his diagnosis. Observing others with differing language abilities, especially those with declining skills, could be harmful to Lewis's mental health and not a therapeutic necessity. Our goals will continue to change depending on Lewis's needs. However, they will continue to maintain functional communication while building on his stronger language skills.
Here are some questions for you all to consider. 1. What indicators suggest that Lewis's deficits are consistent with non-fluent or agrammatic PPA? 2. Throughout Lewis's treatment, we chose to assess the progression of his PPA using the PASS and the GDS when assessing his wife's mental health. What vital information may these assessments give you as a clinician when creating a plan for therapy to continue with in the future? 3. Given the nature of the diagnosis, how would you, the clinician, approach counseling Lewis and his family through the progression of his condition? 4. Keeping in mind that Lewis currently presents with mild deficits, what would you prioritize during treatment as his disease progresses to help maintain communication abilities? Thank you for listening to our presentation. We hope you are all staying safe and healthy during this time.